article live in our series with the Low Carb USA. And guess who we have here? Our old friend, Dave Feldman. So Dave, you want to tell us a little bit about what's going on with you and Nick and Matt Budoff and all that crowd?
Yeah, well, we've just now, I think I can say this, probably within a matter of 1 or 2 weeks, the match analysis, where our study with lean mass hyperresponders and nearly lean mass hyperresponders, they're getting matched with Miami Heart, which is
the Miami Heart study. Yeah. I wondered if that was you were gonna get more analysis on that.
And it's going to be published. That analysis will be published in the next week or two, and maybe there'll be some more data getting released on that soon than what's already been discussed.
I knew it.
Yeah.
I'm excited. So it's coming up Sunday, right? Oh, well, no, you've got some. What have you got coming up Sunday?
Yeah, so I have some new data that I'll be releasing on Sunday. Maybe it has to do with actually, I think I've already dropped at least enough information. It's going to have to do with our study, with our lean mass hyperresponder study.
Okay.
And then, of course, there's the major endpoint to the whole study, which is the longitudinal data.
Right.
And that'll be due out, I'm not exactly sure, but it's probably within a matter of months.
Right. So I've always wondered, as an epidemiologist, there are ways you can figure out by looking at how long somebody's been on a diet, get some indicators of longitudinal impact, even though you're still looking cross-section.
Yeah, I mean, the average time, this is part of what blew me away, and I think I told you this in our talk before. The eligibility was that you needed to be on keto for at least 2 years and then have all those other markers that are the triad. When I found out that our average time was 4.7 years, like nearly half a decade, I thought, wow. And this gets to your point. Okay, well, now, even if we didn't know exactly what their levels were before that, we will have known they were half a decade at these levels, which are in the top 10% of the top 1% of the whole population. So for sure,
1 in 1,000.
Yep. So we'd see a lot of exposure.
So this is still more follow-up on that group of 100?
Yes.
Okay.
Right.
So do you have anything else going on with your study group where you're looking at other folks, or is it all going to be on these folks, more studies on this group of 100?
Well, we just did a conference called COSI, Collaborative Science Conference, which was in March, and it's a fundraiser for our next study. We have a companion study that I'm sort of calling the Triad study for the time being. And it's going to be more relaxed than in its criteria than our current lean mass hyperresponder
that's a big
study.
deal for us.
Yeah.
Because we've got so many, we see more and more people all the time, and they just don't quite fit your very tight definition.
Yeah, well, I mean, this is where it got tricky, because at the time that we were trying to put together this original study, it was already a bit of a push to get it through IRB.
Sure. Yeah, I get it.
So only if we had data in hand from this current study where we could say, this doesn't look like a high-risk population,
right,
could we then get a more relaxed criteria where, for example, we could get people that might have lower HDL and higher triglycerides relatively, but also other risk factors. So for example, some people had a little bit of a history of smoking, some might have had a prior diagnosis of diabetes or hypertension, things along those lines. And I can't say for sure which of these may be part of what's relaxed and what isn't. That's still getting negotiated. But the point is, it'll be a population that has some level of greater risk relative to what we have now, such that we can add to the further data to find out.
So when you're talking about negotiations, is this mostly with human subjects review or with funding agencies, or both?
It's a combination. So of course I have existing donors, some of the bigger donors, we're listening to what input they have for what they would be willing to help contribute and help us out with, but also with Dr. Budoff and his team themselves, as far as what's permissible and what we think we can get through IRB relatively quickly. And we're getting there. We're almost there.
So having spent a little time in in the research space myself, but 30 years ago. I would guess that you're probably, and knowing what I know about what's going on with you, I would guess you're probably not getting all of the angry pushback that you did before.
I think that'd be fair within the research gauntlet itself.
So the ripples are starting to expand. So it's not like everybody right up next to your face is telling you you're a nutcase anymore. But, you know, maybe
on the inside, right?
Yeah.
So on the outside, there are some, I'm sure you see them on social media, who tend to be a lot more vocal. But I kind of bring this up as sort of a bellwether, you know, sort of something that you can check in. I really do think if we were to go back 10 years ago and we were to go to, like, say, you know, a bar at a lipidology conference in the evening and place a bet, say, hey, we're going to have a study in the future where the average LDL is 272 milligrams per deciliter, and capturing their plaque after 5 years at those levels, I'll bet everyone in the bar would take us up on that, right? But I'll bet you today, you wouldn't get as many takers on it, especially if you said they were lean mass hyperresponders. And I think that's I think it's because they have their own patient pools.
Yeah.
They talk with each other, and you know, I'll always caveat, this is still population level data. Whatever somebody's individual circumstances are, they should work with their doctor. They may have something distinctive. So I don't want to make it sound like lean mass hyperresponders, I believe, are just immune from cardiovascular disease. Right. The question is, as unique of a population as they are, and because it's baked into their phenotype, the high HDL, low triglycerides, which tends to associate with good metabolic health, at a population level, are they high risk? And I think 10 years ago, it would have been an emphatic absolutely.
Absolutely. 1 in 1,000.
Today,
not so much.
Well, I'll just say that the opinion, getting back to what you were talking about, the opinion feels different than it was before.
So, on a personal basis, what portion of your time is involved with this? Is it like 100% of your time right now?
Not 100%. I would say that it's research-related endeavors. I want to say it's probably close to 50 to 60%. There is a lot more that I'm doing on the technology end now, which ironically feeds into it.
Like what?
Well, not to plug it, but you, of course, have heard of Own Your Labs. That's our blood testing reseller service. But part of it is it's kind of a gateway for we at checkout, we want to have a checkbox where people can contribute their anonymized data for citizen science.
Okay.
So we're working on the next generation of that. If they check that box, they get a discount. But for that discount, they need to fill out a little more demographic information. Mm-hmm. And then we're ultimately going to have a citizen science data archive that's going to be open to everybody, you know, to basically be able to do their own research on it.
So when you say 50% research and then the rest of it technology, it's technology supporting this research.
Pretty much, yeah. Like it's, so Own Your Labs, for example, backstops a lot of our endeavors with the Citizen Science Foundation. Mm-hmm. And to be fair, probably a good 20% of my time is administrative. Which,
all those different activities.
Yeah, like for example, organizing the next COSI conference. It's a lot of work.
Oh, yeah.
Conferences can take up a lot, but it's basically a fundraiser.
And Dr. Brewer, I have a question. Can you ask that real quick?
Oh, yeah,
just in case the microphone doesn't catch it.
What's that?
Can you ask Dave if he, on his opinion, is LDL and Apo B, without a doubt, the cause of heart disease?
I'll ask him.
In his opinion.
Okay. So Dave, in your opinion, are LDL and Apo B, what did you say?
The cause
of heart attack and stroke.
So as you know, it's a little bit of a kind of, I don't want to say trick question.
I'm going to interrupt and say it's interesting to watch you field this question, by the way.
Yeah, yes. So this is something I think a lot of us who are more into the nuance of the lipid energy model, including my good friends and colleagues, Nick Norwitz, Adrian.
Yeah.
They would say, look, without question, Apo B containing lipoproteins, including LDL, are part of the causal pathway of atherosclerosis. Now, I like to bring up this analogy to kind of illustrate what the problem is, which is car tires and car accidents. Are car tires part of the causal pathway to car accidents? They are, right?
Yeah,
Okay,
they're
but
certainly
do-
involved. At
But
some
do
point.
car tires drive car
automobile
accidents,
accidents?
right?
No.
Yeah, so, well, so this is the challenge. The challenge is if
Yeah.
you can do an intervention where you remove car tires, if we ban all car tires in this town, would we have less car accidents? We would, right?
Yeah. Oh,
Okay. Would there be a net improvement on, well, for one, we would see less vehicular accidents and therefore less death that way. But also, there'd be less people who could get to the hospital.
Yeah. The economy would shut down.
So then the question is, what's the trade-off? Is
Yeah.
there a trade-off? And to answer that question best, knowing that I'm saying what I'm saying, which is it's part of the causal chain, we need to look at it in the case of healthy individuals. Because the thing that you and I had talked about in depth before, that I zero in on all the time, is LDL being increased can be increased for more than one reason. And that's important. If your
Of course.
metabolic
Absolutely.
health changes your lipid profile and also your metabolic health changes your atherosclerotic risk, doesn't that mean we have a confounder to looking at those two comparing each other?
Yeah.
We do, and that's why we've always needed to do this research. We've always needed
Yeah.
to look at people where we isolate that variable by itself, where we isolate high LDL and high Apo B by itself. So to really best answer the original question, unfortunately, we needed to get to this point in time where we got this population with sky high LDL, sky high Apo B. Will they demonstrate an association with cardiovascular disease? And that's what we're gathering right now.
More to come this Sunday and over the next couple of weeks in terms of publications.
Yep, and it'll be different. Once more is published, then we can have, I think, a broader conversation about it.
Yeah. As you know, I look forward to it. I can afford, because I'm peripheral to that debate right now, I can be a little bit more loose-lipped, and I think clearly genetics is driving a whole bunch of this. And I think there's a lot more biomarker component going on in here than just driving. And so, for example, your mechanism about tires, I think is a very apt one.
Right.
Yes, it's involved, but it's not driving at all.
Well, it's the same challenge you would have in, say, identifying monocytes. Monocytes become macrophages.
Right.
If you had a drug that radically reduced monocytes, would you get less cardiovascular disease?
Not if people ignore their metabolic disease.
Well, it's a
Which
component.
is exactly what's happened with statins. You know, we think, okay, we're going to lower LDL, and that really hasn't chipped away too much at cardiovascular disease.
Well, this is the thing I think everybody should be agreeing on.
Yeah.
We should just all be talking about metabolic health more
Yeah.
than we talk about LDL.
LDL.
Wherever you stand
Absolutely.
on LDL, right? So you can be completely pro-lipid hypothesis, and if you are, look at the hazard ratios against diabetes. It's not even close. Yet, when we're talking about cardiovascular disease in general, or when the broader public is, when it's on social media, it's almost always in relation to ApoB and LDL. There's almost never a discussion about diabetes specifically towards cardiovascular disease.
Well, as you know, Jesus and I both went to medical school, and we both know, doctors know metabolic disease is a driver. They know that when somebody's got diabetes, it's going to rot their arteries. What they don't know is how prevalent diabetes and pre-diabetes is. 73/4 of them don't know how to diagnose pre-diabetes. And that's not me saying that, that's clear evidence that's out there from Hopkins, from Mayo, from plenty of other organizations and their research. So until we begin to understand metabolic disease before it has totally blown somebody's arteries out, we're going to continue to have this problem where we're majoring on the markers.
But that's what you're getting to is exactly why I feel this research, I'm hoping, will help us if we ultimately are in agreement that the lipids are a distraction
Yeah.
from the root cause. So it's not just that the root cause is known to us, or at least I shouldn't say that it's known to us, that a major root cause of cardiovascular disease isn't just known to us. I feel there's a shinier, brighter object in the room that keeps drawing the attention.
Yeah.
Right. I myself, I think back to the work of Joseph Kraft.
Yeah.
Like, he should have a Nobel Prize right now, right? That should be like awarded to him this moment, because he was detecting the downfall well before it takes hold,
Yeah.
right? And yet, here we are today at around that same time he was doing his experiments in the 70s, just also the days of Brown and Goldstein.
Yeah.
But that's where all the discussion is. And I think it's because there's something that can be done about that relatively quickly. But
Drugs.
but the return on investment, again, you can be completely pro-lipid hypothesis. The return on
Yeah.
investment for tackling your LDL when you're metabolically unhealthy, you should be tackling your metabolic health for sure, no matter what. It's your biggest cardiovascular disease risk.
Well, I don't know if you remember that day that I screwed up the call. You and Nick and Adrian came, and I was running around trying to find signal on my phone. But that was the issue for me. I want to get this out of the way,
Yeah.
this LDL, so we can focus on the real animal here, the real cause, the real problem.
And this is something you'll hear me concede over and over again, including with this research we're doing right now. It may well be, and I'll concede as a good scientist, that there is some amount of margin of pathology, atherogenicity, with
there is.
high levels of LDL, but it's just very small. That's possible. I don't know that I would commit either way, because it's hard to detect that, right? But when you have people with hyperinsulinemia, they're on their way real quick towards severe cardiovascular disease in their life, far faster, right?
Yeah.
It's something you can see that fast.
Well, Jesus can tell you. I mean, up until, well, I guess it was about 6 months ago, I used to say, I get these, some lean mass hyperresponders, I get a lot of FH patients where the LDL is sky high and everything else looks good except they've got this niggling little LPPLA2. And I don't know in your world if you get that deep into it.
Oh no, I do. I've probably had over 100 LPPLA2 tests.
Okay, so for some reason,
It tends to track with LDL particle count.
oh, well, you may know. You sound like you have some opinion on it.
Yeah,
Tell us a
so-
little bit more about that.
So LPPLA2, if memory serves, is the enzyme that cleaves the oxidized phospholipid from LP little a, right? Or sorry, other way around. It cleaves the oxidized phospholipid from Apo B containing lipoproteins, often in conjunction with LP little a, right? The catch is, like so many things that are metabolic related, we don't know how much of the synthesis of these components of the lipid profile are piggybacking on the larger fat-based metabolism, right? Now, there's a simple test for me, which was when I was changing my own lipids through the protocols that I was doing, bringing down the amount of food I was eating so that my lipids would go up, bringing up the amount of food I was eating so that they would go down, to see if these levels rose and fell with them, right? Now, when they do, it tells me one of two things and possibly both. One is that there could be something with the assay itself. That's the case with ox LDL, by the way. Oxidized LDL is not the best test in my opinion. I like ox phospholipid Apo B, but we'll set that aside for a second. But LPPLA2 likewise tracks, it's highly correlative. I think memory serves. I think when I ran it on my own test, because I told you I've had over 100, against when I've had NMRs, it tracked with LDLP with a regression of around 0.85, something like that, right? But the point is, because it was going up and down, I then reached out to the community. I was saying, how often do you guys see LPPLA2 associate with LDL particle count? And it was extremely common, right? And
So, I get that. So do you have evidence that makes you feel like it's a spurious test, or you should not, it doesn't mean anything in terms of risk?
So I'm going to emphasize we now come back to context. To make it simple, there's two buckets. Bucket one is the one we're usually studying, which are individuals for which there is an immune response. They are inflamed.
Mm-hmm.
So inflammation, systemic inflammation is in play. Now, why this is a big confounding bucket is because a lot of our lipid numbers are acute phase reactants themselves. For example, LP(a) is an acute phase reactant, right? For your listeners, an acute phase reactant is a protein that's 25% or higher, or has increased 25% or more in the case of where you have systemic inflammation, right? So in the case of LP(a)2, I wouldn't be surprised if, like LP(a), it's increased in the circumstance of inflammation. Okay, now you have this other bucket, which I was just talking about. If I can move those numbers around with just changes in diet, by fat adaptation, so they seem to piggyback with the larger fat adaptation milieu, the lipid energy model, I need to start treating these as two separate things. I need to be able to find studies where there's LP(a)2 high, but inflammation low.
Well,
right?
yeah.
And the problem is there aren't a lot of studies, but those that do don't seem to find a higher association of risk. Usually there's adjustments involved in order to find it.
Well, so I may be able to contribute a little in that space because we follow a panel of CRP, high sensitivity C-reactive protein, myeloperoxidase, and microalbumin creatinine ratio. And what we tend to see with the LP(a)2 is it's just that one.
Yeah.
It's not the others. And so I've often wondered that too.
Have you found
worry, given what I know about homozygous FH kids, 15 and 20-year-olds having heart attacks with the history, some of that back in the history. So I worry about that, and I see these patients that you're talking about that have LP(a)2 elevated, but nothing else, and I just worry.
Is it in the 200s and low 300s?
For
LP(a)2.
Actually, quite often it's even less.
Yeah. So my own, by the way, is in the 200s. I want to say, so it
Routinely?
bounces between like 220 and 280ish, something like that, in that realm.
Have you gotten MPO, microalbumin? I'm sure you've gotten microalbumin creatinine.
I don't think I've gotten that. Well, I've gotten creatinine. I don't know that I've gotten that specific test, but I'm happy to get it.
I'd love. We'll send you one of our panels.
Yeah.
I'd love for you to do it.
Happy to take them on. Listen, it's been a while since I've been hitting myself with the full complements, but I've had so much wide spectrum testing in my life. Just all this admin stuff has kind of kept me away from my original N of 1 experiments that I used to do back in the day. And again, I mean this when I say it. I don't want to sound cavalier as though I'm certain everything's fine, either with myself or with all subsets of lean mass hyperresponder population or anything like that. But that said, do I also tend to find that this bucket I was just describing not only gets very little research applied, but that there's a total lack of curiosity, a shocking lack of curiosity in looking to folks who are metabolically healthy and fat adapted, because I think they're going to teach us so much about the physiology so that we can better understand what's going on. And that's what we're hoping to break through. It's not even just trying to find out how much LDL associates with risk or not. Yeah. It's trying to open this door for literally the field that's supposed to be the most interested in lipids, which is lipidology.
Right.
And that's been the challenge, right?
That's been the challenge. And I'm not being cavalier at all. I mean, as you know, we do this all day, every day with patients, and I'm very, very clear that whatever risk there may be with these really high LDLs, it's nothing compared to the the oceans of risk associated with undiagnosed metabolic disease.
Absolutely.
So,
Absolutely. It's funny because I feel as if a lot of times detractors almost kind of answer yes in a hand wavy way. Of course. Work on your metabolic health too. But
let's get that LDL.
let's
down.
get back to the thing I was
LDL.
just talking about that I'm making my 18th video on, how best to lower Apo B and so forth.
I know who he's talking about.
I got some follow up on that. I'll
Yeah.
share with you in a few after the.
And it's
after we're done.
like again, lipid hypothesis could be true. Again, it could be that there's some margin, but we already have both observational data, we have experimental data. We see what difference it actually makes relative to improving your metabolic health.
Yeah.
And it's just not even close at all.
No.
It's not. So it's not a hand wavy thing. Spend at least as much time talking about how to work on that, I think, than changing your lipids. But that's just my 2 cents.
Well, I think we've gotten to the core issue, and I really appreciate your time. Is there anything that I haven't asked that I should have?
No, but I think you'll want to ask more questions later.
Over the next few days.
Yeah.
I think so too. I'm very excited to hear what you've got going on.
Yeah, I'd love to come back on when I got some new juice to put in the tank. Yes.
We will set it up and figure out when you think. I mean, you've got a bunch of stuff coming out
Oh, yeah.
over the next 2 to 3 weeks. So maybe 4 weeks from now or something like that.
Yeah.
Maybe you're too busy 4 weeks from now. Maybe it should be 5, but don't put us off too long.
No, we'll figure it out.
Sounds good. Thank you again.
Thanks for having me.